Hello, this is Chris from Maryville University. For my case presentation, I chose to use a 54-year-old African-American male patient who I saw at the cardiac clinic with my preceptor. Basically, this gentleman's chief complaint was shortness of breath. For the history of present illness, it's a 54-year-old African-American male patient with history of non-ischemic cardiomyopathy, which was post-viral and was diagnosed in 2009. His last known EF was 10%, which was documented in May of 2014. Other history: hypertension, hyperlipidemia, history of multiple admissions for heart failure, despite overall compliance with medical management, who presents to Piedmont Fayette Hospital with worsening shortness of breath and exertional tolerance. The patient was diagnosed with dilated cardiomyopathy secondary to viral myocarditis in 2009 after having a cardiac angiogram, which was negative for ischemia and resultant cardiac MRI, which showed the aforementioned diagnosis. Patient states that since last discharge from hospital, which was in October of 2014, his exertional tolerance has worsened and is now very limited. He states that at best he cannot perform ADLs, such as tying his shoes, without dyspnea. He reports chronic 3-pillow orthopnea, poor appetite, and dry cough. Symptoms moderately improve with rest and are aggravated by prolonged movement. He denies any focal infectious symptoms, denies recent febrile illnesses, reports compliance with prescribed medications and sodium-restricted diet, non-compliance with daily weights. Patient also describes episodes of palpitations at rest that resolve spontaneously. He denies AICD shocks or syncope episodes. Patient last had device interrogated October of 2013, is not aware of any device adjustments. Only past medical history is the viral cardiomyopathy with resultant heart failure and ejection fraction 10%, hyperlipidemia, and hypertension. Past surgical history was a AICD implant, which was for the congestive heart failure, or secondary to, and that was placed January 23 of 2014. As far as family history is concerned, his mother is alive with hypertension. Father is deceased from gastric cancer. Brother is alive and well, sister is alive and well. Regarding social history, patient's never been a smoker, no tobacco use. As far as ETOH, occasional beers in the past, states that he's had none in the past 10 years. No recreational drug use. Occupation, he's on disability. So there's no occupational exposures. He is married, uses home smoke detector. As far as travel, no recent travel outside of the U.S. Diet and exercise, patient states adhering to low sodium diet, decrease in overall appetite and since worsening of shortness of breath, denies exercise due to limited exertional tolerance, basically gets too short of breath with any kind of activity. Insurance provider is Medicare, education, high school diploma. Regarding home medications, Coreg 3.125 milligram BID, Dig 125 mic tablet once a day, Rivaroxaban or Xarelto 20 milligram tablet at night, and Rosuvastatin, his statin cholesterol medication, 10 milligram tablet at night. Allergies, his only allergy is spironolactone. Vaccinations, I ordered this patient a influenza vaccination since he had not had one so far this year, and stated he didn't have one last year also. Regarding review of systems, starting with his constitutional, he reports fatigue and shortness of breath upon exertion, reports decreased activity tolerance and appetite, reports occasional dry cough, denies recent weight gain or loss, denies fever, night sweats, or chills. Head and neck, denies any lightheadedness, dizziness, vertigo, single episodes, or recent head trauma. EENT is essentially negative, but he denies any recent change to overall vision or ability to carry out ADLs. He does state wearing contact lenses. He denies blurring or diplopia. As far as ear, nose, throat, denies any ear pain. Denies wearing hearing aids, and denies alterations in balance. Denies nasal pain, changes in ability to smell, nosebleeds. He does report occasional dry cough, denies throat pain and hoarseness, and denies bleeding of the mouth or throat. Cardiovascular does report occasional palpitations that spontaneously resolve, reports increase in shortness of breath and fatigue, likely secondary to the CHF. Reports increased swelling of extremities, denies weight gain, denies syncope, lightheadedness, chest pain, or claudication. Respiratory report shortness of breath with minimal exertion, denies cough, wheezing, or hemoptysis, denies history of sleep apnea, COPD, asthma, or TB. Gastrointestinal, essentially negative, denies abdominal pain, denies blood in stools, diarrhea, or loose stools. Genitourinary, negative as well, denies pain, urgency, dysuria, nocturia, UTI, denies history of sexually transmitted infections. Musculoskeletal, he denies decrease in overall strength, denies deficits in range of motion, denies back pain, myalgia, or carpal tunnel syndrome. Neurological, denies seizures, tics, paralysis, tremors, denies deficits in coordination or memory. Skin and hair, negative as well, no rashes. Dryness, abnormalities in skin pigmentation, changes in hair and nails. Endocrine does report overall decrease in energy level. That's likely secondary to the CHF and low perfusion output. Denies recent weight gain or loss. Denies heat gain, heat or cold intolerance. Reports decrease in appetite since worsening of symptoms, which is common in patients such as this. Hematologic, denies history of anemia or bleeding clotting disorder. He does report bruising easily secondary to Xarelto therapy, also common as well. Mental health, denies depression, anxiety, nervousness, mood swings, hallucinations, or suicidal thoughts. Denies mental or physical abuse. Moving down to the objective exam. Physical examination, temp was normal, 35.2 degrees Celsius. Blood pressure was low, 87/70, also common in patients with low output syndrome, secondary to CHF. Pulse, 53 beats per minute. Irregular rhythm. Patient came in with AFib. Respiratory rates normal at 20. Oxygen on 3 liters, 99%. Like stated before, just exertional dyspnea. Height and weight within normal range. BMI was 28.3, so the patient is overweight. And moving to the physical exam, general appearance was mild acute distress. Wakeler Orient ×4, perfectly groomed for the environment. Responds appropriately to questions. This particular patient would get shorter breath upon extended talking. Started to get tachypnic, which was noticeable. Head, normal cephalic, atraumatic, no apparent lesions. Masses of foreign bodies. Skin, warm, moist, and elastic. No diaphoresis noted. No cyanosis, clubbing, deformity to the digits or nails and upper lower extremities. Nail beds were pink. Capillary refill was less than 3 seconds. All extremities warm to touch. Pulses were 2+ throughout. There was 2+ edema noted to the thigh, pretibial, and ankle areas bilaterally. Eyes, essentially negative. Extraocular muscles intact. Eyes reactive bilaterally. Pupils equal and reactive. ENT, no tenderness. Palpation of ears, nose, or sinuses. Ears were negative. Tympanic membranes were clear and intact. As far as the nares, septum terminates regular. Lips, teeth, and gums all appear healthy. Moving down to the neck was supple, non-tender, no lymphadenopathy. Respiratory, this is where changes were seen. There was symmetric chest rise, no use of accessory muscles. However, crackles were auscultated in the lung bases bilaterally, otherwise clear throughout. No rhonchi, wheezes, rails, or rubs. Patient did become dyspneic with prolonged speaking, as I mentioned earlier. Cardiovascular, irregular rate and rhythm. There was an S1, S2 auscultated. No murmurs, as mentioned previously, 2+ edema to the thigh, pretibial, ankle areas bilaterally. JVD is also present at the angle of the jaw at about 9 centimeters. Also common in these patients with so much resistance to the output. You tend to see the bulging jugular veins. 2+ carotid artery pulses bilaterally, no bruits. Telemetry showed sinus bradycardia. So I apologize for earlier. He has a regular rate and rhythm. No AFib with this patient. EKG was pending when we saw the patient. As far as abdomen, soft, non-tender, bowel sounds normal active. Genitourinary was deferred in this particular patient. Primary focus was respiratory and cardiac, of course, and then relevant systems to that. As far as musculoskeletal, the neck and shoulders were stable, no tenderness, range of motion with normal limits, joints stable. Neurologic, no focal sensory or motor deficits, thought process was coherent. Psychiatric, patient exhibits no deficits of insight or judgment, no apparent deficits in recent or remote memory, mood and affects are congruent with the environment. As far as the assessment or the plan on this patient, the problem list included advanced non-ischemic cardiomyopathy, which was previously diagnosed, but that was his primary presenting issue. Differential diagnoses included myocarditis, infective endocarditis, familial dilated cardiomyopathy, and systolic heart failure, which with his ejection fraction of 10%, he's definitely in systolic heart failure. Palpitations was the second problem. Differential diagnosis, valvular disorders, anxiety, and electrolyte imbalance. And 3 was hyperlipidemia, common with almost majority of cardiovascular patients. Differential diagnosis, mixed hyperlipidemia, unspecified hyperlipidemia, familial hypercholesterolemia, and idiopathic hypercholesterolemia. Diagnostic tests that we performed on this particular patient: chest x-ray, EKG, transthoracic echocardiogram, CBC with diff, a complete metabolic panel, BNP, usually anything over 100 is diagnostic for heart failure. This particular patient, we'd expect it to be much higher than that, given that the ejection fraction is only 10% at this time. PTINR, TSH, fasting lipid panel. Regarding the treatment plan, for this patient, we went ahead and started him on a milrinone drip at 0.25 mics per kg per hour. Also initiated IV diuresis, wanted to get fluid off, make it easier for the heart to contract, pump effectively. Plan on placing a PICC line for the patient. He'd be in the hospital at least a few days, if not a week or longer. Plan to monitor the potassium, magnesium, replete as necessary. Continue home doses, Coreg, digoxin, and statin medications. The patient was started on Inspira, 25 milligram tablet Q day. Also started on lisinopril, 5 milligram tablet Q day. Patient was admitted to cardiac telemetry floor for close monitoring, AM labs ordered. Daily weight, strict eyes and nose, low sodium diet ordered. As far as the second issue, the palpitations, currently sinus brady, occasional pace beats on telemetry is what this particular patient was showing. As I mentioned, he had the AICD placed in the past with the pacemaker pacer combo. Waiting EKG, continue home dose of Coreg. Parameters in place for DIG, hold if the heart rate's less than 60. Patient was admitted to cardiac telemetry unit for close monitoring. Orders placed to have the brain of the AICD identified. We didn't really know the particular brain for this patient. He didn't know either. Interrogation was performed on the AICD. Daily chemistry ordered, or replete electrolytes as necessary, as I mentioned previously. As far as hyperlipidemia, continuing home dose of Crestor. Patient was on cardiac sodium restricted diet. We were awaiting his fasting lipid panel. As far as follow-up, consults or referrals, since this was an inpatient case, we were going to continue to follow the patient throughout the course of the treatment. Monitor him closely for improvement from prescribed therapy. The patient was admitted to a cardiac telemetry floor. Also continuing to follow lab work. This particular patient was scheduled for a transthoracic echo in the morning just to reevaluate his ejection fraction. Also look to see if there are any valvular issues. Counseled the patient at length regarding diagnosis, treatment, medications, exercise, and dietary regimen, which usually cover with each cardiovascular patient for the most part. As far as this particular patient, since his EF was so low and with his exertional tolerance, more than likely we'd refer him to a cardiac rehab program post-discharge, depending on how well he does with milrinone therapy, things such as that. We can always send him to a rehab facility with the PICC line still in. He can receive the milrinone therapy, hopefully wean him off that as he progresses through the cardiac rehab program. Also reminded the patient of the importance of obtaining daily weights at home and reporting abnormalities to his primary care provider. And with the exception of that, just continue to follow him throughout his stay at the hospital. And that is all for my particular patient case. Thank you.